Assalamu alaikum wa rahmatullah. Good morning, everybody. This lecture will be about traumatic brain injury in case scenario. You have been called to see a patient who is 37 years old, included in road traffic accident nearby hospital. So, what is your approach to the case? Definitely, the answer will be ABCDE approach. So, airway should be assessed and protect at the scene. So do rapid assessment for the GCS and consider the motor part of the GCS. Also consider cervical trauma and use Mills maneuver for intubation. And definitely consider rapid sequence intubation in this scenario. The drug used for intubation, opioid like fentanyl, 1 to 3 mic per kg as analgesic. Also you can use midazolam instead of ketamine. And be careful about the endotracheal tube. Tape it but not tie. For protection of the cerebral perfusion pressure at the level of the neck. Also assume full stomach and apply orogastric tube immediately together with ETT. For breathing you have to apply capnography for confirmation of intubation first, and then for continuous monitoring and assessment of exhaled carbon dioxide as part of brain protective strategy. Also keep oxygen supplementation and always maintain the saturation between 92 and 98%. After securing airway and breathing, immediately go to circulation and introduce 2 wide bore cannula. Then take blood sample for blood group immediately and complete blood count, arterial blood gases and other investigations. Immediately after sampling, give a bolus around 250 up to 500 ml of normal saline, or better to be hypertonic saline. Check the blood pressure and ensure that systolic blood pressure above 110 mm mercury. Always remember to keep mean arterial pressure above 80 mm mercury to achieve adequate cerebral perfusion pressure between 60 to 70 mm mercury. Definitely in traumatic brain injury you have to avoid albumin infusion because any colloid increase mortality in traumatic brain injury. For disability you have to check the primary GCS at the scene and pupil diameter and reactivity because it's very important and predict the mortality. Also don't forget to check the temperature of the patient at the scene, and if it is high, try to avoid high temperature using cold sponge or ice bag or any other external method to decrease the body temperature. Because as you know, high temperature increase the metabolic rate of the brain. And never forget to check the blood glucose of the patient and to keep it and maintain it always during the disease course between 140 up to 180 milligram per deciliter. About exposure, you have to check other trauma site in the patient to exclude other comorbidities with traumatic brain injury. This is the most slide important in this talk, which is brain protective strategy in concise, and you have to take it as a poster. The brain protective strategy include 9 items. First, elevate head of the bed 45 degree, then full sedation and analgesia for minimum 5 to 7 days. Keep the mean arterial blood pressure above 85 mm mercury and systolic blood pressure above 100 mm mercury. Monitor the exhaled carbon dioxide and keep it between 35 up to 40 mm mercury within normal. Maintain oxygen saturation between 92 and 98%. Don't forget to keep the blood glucose between 140 over up to 180 milligram per deciliter. Serum sodium should be kept above the higher limit of the normal between 145 up to 155. And the body temperature of the patient always should be kept within normal between 36 up to 37.4. You have to avoid hyperthermia all the time. Finally, don't forget to give prophylaxis anticonvulsant for 5 to 7 days. How to manage high intracranial pressure? As I mentioned, full sedation and analgesia for 5 to 7 days help in decreasing metabolic rate of the brain. The second thing is to maintain the serum sodium between 145 up to 155, and this is through osmotherapy, which is given in 2 drugs. The first one is hypertonic saline, 3% in dose of 1 to 2 ml per kg every 6 to 8 hours, targeting serum sodium 145 up to 155 and osmolarity to be less than 320 mg per deciliter. It improves cerebral blood flow and decrease the ICP through osmotic shift. The second drug is mannitol and is unpreferable for us as intensivists. The dose of mannitol is 0.25 to 1 gram per kg every 4 to 6 hours, targeting osmolarity to be less than 320 mg per deciliter. The difference between hypertonic saline and mannitol, that is, hypertonic saline is more safer than mannitol, while mannitol can cross the blood-brain barrier and cause many complications, leading to rebound, increasing the intracranial pressure, and electrolyte disturbance such as hyponatremia and hyperkalemia, and severe metabolic acidosis, and severe hypotension. The external ventricular device have 2 roles, diagnostic and therapeutic, for increasing intracranial pressure. Also, you can use barbiturate such as pentobarbital to achieve burst suppression by this sedative drug. And you can monitor electrical activity by using electroencephalogram or by spectral index. Remember, all time you maintain normocapnia, but sometimes hyperventilation targeting to decrease exhaled carbon dioxide to below 35 mm mercury. This is just done when the patient have refractory ICP and on his way to theater for surgical intervention to decrease intracranial pressure. In some cases, hyperventilation or exhaled carbon dioxide monitored by jugular bulb oximetry, and this should be between 50 to 75% as normal. Remember, all time remember to keep normothermic. Patient normothermic. Don't apply hypothermia because it is associated with high mortality. Decompressive hemicraniectomy is a method of surgical intervention. It improves the mortality, but on other hand, it associated with increasing disability. How the ICP is arised, and this is result from respiratory wave form, which is 0.1 to 0.3 Hz, associated with respiratory cycle. And this type of wave, called C wave, it takes 0.5 to 2 minutes in interval. It is normal wave type of ICP. Secondly, the cranial pressure waves arise from frequency or pulse pressure equal to the heart rate. This is called peak wave, and it composed of 3 types of wave, P1 and P2 and P3. P1 is percussion wave, P2 is tidal wave, and P3 is dichrotic wave. The third type of cranial pressure wave results from slow vasogenic wave. This type of wave is 2 types, Lundberg A, which is always pathological, and Lundberg B, which is physiological. It takes from 4 to 8 minutes, while Lundberg A, it takes more than 20 minutes. Just for repetition, the C wave of ICP results from respiration variation, and the 3 peak wave, P1 and P2, P3, resulting from pulse pressure variation, while Lundberg A and Lundberg B Both result from slow vasogenic wave. B wave is short repeating elevation in ICB from 10 to 20 mm mercury with frequency of 0.5 to 2 wave per minute. It is not of value clinically. Lundberg A is always pathological and it takes 5 to 10 minutes. The pressure is more than 20 mm mercury. Normal ICB 5 to 15 mm mercury. Peak 1 or percussion wave represent arterial pulsation, while P2 or tidal wave represent cerebral compliance, and P3 or dichrotic wave represent transmission of the closure of the aortic valve. If P2 taller than P1 indicate high intracranial pressure, that means very low compliance of the brain. If P1 taller more than usual and sharp in comparing in P2, that means very high systolic blood pressure. There is 4 advanced modality to monitor the ICB. The first modality is jugular bulb oximetry. The normal jugular bulb oximetry is 50 to 75%. It is device directed to the cranium, inserted in the internal jugular vein. If it is less than normal, it means either increase in oxygen extraction by the brain, which indicate high metabolic rate of the brain, or decrease in cerebral blood flow. Jugular bulb oximetry is used to monitor hyperventilation during osmotherapy. Second parameter is brain tissue oxygen monitor. The brain tissue oxygen monitor is an electrode placed in the brain tissue or brain region that affected by hypoxia. Therefore, persistent hypoxia of the brain defined as brain tissue oxygen monitoring less than 20 mm mercury. It associates with poor outcome of the traumatic brain injury. If brain tissue oxygen monitoring less than 20 mm mercury and at the same time hemoglobin of the patient less than 7, this indication of red blood cell transfusion to increase oxygen carrying capacity to the brain, and it is associated with good outcome. Third parameter to monitor the ICB is cerebral microdialysis. It is a catheter placed on the affected tissue of the brain in between the interstitium of the brain. Then frequent interstitial fluid sample taken and read in the ABG machine to compare lactate to pyruvate ratio. If lactate to pyruvate ratio is high, this indicates brain tissue ischemia, which is poor prognosis. Last parameter is transcranial Doppler. This allows the visualization of cerebral blood flow in the circle of Willis, or allow the pulsatility index. We can calculate the ICB, CBB at the same time. Antibiotic is not recommended as prophylaxis in TBI unless there is penetrating TBI. Also, steroid is not recommended in TBI because it increases mortality. Tranexamic acid can be given in the first 3 hours in the ER according to CRASH 3 trial. It associated with good outcome. Albumin definitely not recommended because also increase mortality, so it is contraindicated in TBI. General ICU measure also don't forget to apply VAP bundle in the first 48 hours, and early enteral feeding with stress ulcer prophylaxis and thromboprophylaxis and physiotherapy. Indication of poor prognosis is absence of bilateral pupil reflex, and motor part of the GCS is less than 2, and absence of oculocephalic reflex and also extreme age and low GCS and presence of extracranial complication. ECG changes in high ICB is T-wave inversion, which is called cerebral T-wave. Also ST segment elevation or depression and elevated U-wave and J-wave. Lung concept is become obsolete. It's just depend on increase the cerebral blood flow of the brain rather than monitor the ICP.